Hello, Chodu. Let's talk about the renal system. The renal system, the first disease is renal tubular acidosis. We know that we have the nephron, and in the nephron, we will talk about the glomerulus. We have PCT, we have loop of Henle, we have DCT, and we have collecting duct. Now, your PCT, this will absorb sodium chloride and water, 100% glucose, bicarbs, and your amino acids. Everywhere in the nephron, there will be absorption of water and sodium chloride because 180 liters of blood is going, 178 liters is getting back, only 2 liters of urine at max we are making. So everywhere we'll be absorbing sodium chloride and water. In DCT, it is divided into proximal and distal. Proximal में sodium chloride and water and calcium दोनों आते हैं. Distal में aldosterone is working because there is a ENaC channel, so sodium chloride and water is getting absorbed and potassium and hydrogen is getting excreted. PCT is excreting urea and creat, and urea is also getting excreted by the DCT. In renal tubular acidosis, what is happening is that we are having damage to the tubules. So either there's a damage of the PCT or there's a damage of the DCT. There is one kind of renal tubular acidosis which is only due to aldosterone dysfunction because the ENaC channel is not working properly. Okay, because of aldosterone dysfunction due to diabetes. So RTA, there are four types: RTA 1, 2, 3, and 4. RTA 1 is due to DCT damage, RTA 2 is due to PCT damage, RTA 3 is mixed PCT DCT, and RTA 4 is due to aldosterone dysfunction. अब देखो, हमें question solve करना है. It's not about what is there in this topic. We have to understand that what is happening in this. आप कैसे याद करो? Every RTA will show you acidosis. तभी तो नाम acidosis है. ठीक है? So HANs will be more inside the blood. Secondly, you just learn three lines. RTA with hyperkalemia is RTA type 4. Hyperkalemia, RTA type 4. RTA with renal stones is RTA type 1 because there will be DCT damage. So you will not be able to absorb the calcium back in the blood. It will remain in the kidney and it will cause renal stones. RTA with back pain is RTA 3. तो आपने ये याद रखनी तीन चीजें. Renal stones 1, you see hyperkalemia 4, and if you see your back pain, something like that, so you talk about RTA type 3. For treatment of these RTAs, you have to give bicarb because acidosis is happening in the blood, so you give bicarb. But RTA type 2 में we are giving thiazides, and RTA type 4 के अंदर we are giving our loop diuretics and like furosemide so that we are managing the potassium levels. That's it. सिर्फ इतना याद करोगे काम चल जाएगा. ठीक है. Then all this is that only. Then you have renal artery stenosis. Renal artery stenosis के अंदर renal artery is getting stenosed. There are three parts of the renal artery: the ostium, the opening of the renal artery, the proximal part, then the middle part and distal part. Most common cause is atherosclerosis seen in smokers, and the second most common cause is fibromuscular dysplasia, which is seen in young females. If the patient is having renal artery stenosis, obviously patient will be giving you refractory hypertension, abdominal brute, and all that. If the fibromuscular dysplasia is happening, then it will lead to beaded appearance of the renal artery. Depending upon, because the patient is having refractory hypertension, the investigation of choice becomes renal artery angiogram, but the initial investigation will be Doppler ultrasound, which will give you turbulence. Depending upon the site, you will treat. If it's a proximal blockage, you give antihypertensives, and if it's a distal blockage, put the stent, which is the technique is PTRA, percutaneous transluminal renal angioplasty. Okay, the best drug to manage renal artery stenosis, the drug of choice for the hypertension in the patient will always and always be your AC inhibitors, but it is contraindicated in bilateral RAS. That's what you have to remember. All right. Then comes after that AKI. AKI beta very simple in acute kidney injury. These things. The Gentleman and the Fanconi and the Barter and the Little syndrome. इसमें भी मोटा मोटा याद करना है अपने को. देखो, if there's a PCT, carbonic anhydrase problem, it is Fanconi. If there is problem in the NKCC channel in the ascending loop of Henle, then it is Barter. If it's a problem with the sodium chloride channel in the DCT, it is Gentleman. And if it is a problem with the ENaC channel, it is Little syndrome. लिटिल सिंड्रोम अपन ने बात किया था बेटा एवरीथिंग विल बी लेस ठीक है एवरीथिंग इज गोना बी लेस इन लिटिल सिंड्रोम because it is due to overactivation of the ENaC channel. Drug is amiloride for ENaC blocker. For Bartter, what you have to remember, in Bartter syndrome, it is with the ascending limb, and a patient with the Bartter syndrome will have calciuria, ठीक? Because of the gradient problem. Whereas with Gentleman syndrome, you have to learn that the patient will be having magnesium problem. With the Bartter syndrome, you are having calciuria, and with the Gentleman syndrome, you will have serum magnesium to be hypomagnesemia milega in patients. Because of these channels getting damaged, the gradient is not being formed, and that is why we are not able to absorb it. ठीक है? Fanconi syndrome, same as carbonic anhydrase problem is seen in RTA type 3. So it is same as RTA type 3. तो कुछ याद नहीं करना है. Little syndrome के अंदर तुमको पता ही है, collecting duct, ENaC channels, इसका over activation हो जाता है, drug is amiloride. So there's no point of learning everything here because at the end you have to solve the question. So if you keep this thing in mind, you will be able to solve the questions. For an AKI, three grades dependent on serum creat and urine output. If the serum creat is 1.5 to 1.9 times grade 1 and urine output, normal urine output कितना होता है 1 milligram 1 milliliter per kg per hour. So if it is less than 0.5 ml per kg per hour for 6 hours, it is grade 1. If serum creat is 2 to 2.9 and the urine output is less than 0.5 for 12 hours, it is grade 2. And if it is more than 3 and the urine output is less than zero point 0.3 for 24 hours or anuria happening for more than 12 hours, then we talk about the grade 3. Okay. Now, this AKI, how do we uh, come to a conclusion that 100% this is AKI by doing, kidney injury molecule, KIM1, the marker of AKI, biomarker. This is the best. This is the investigation of choice. Any AKI can be due to three reasons. Either it is the problem before the kidney, or in the kidney, or after the kidney. Most common cause is pre-renal, the hypovolemia, that the kidney is getting acutely injured because kidney is not getting the blood. ठीक? So AKI, most common cause is pre-renal, that is hypovolemia. Now, post-renal, there are obstructive causes, so very easy to find by the imaging studies. But for a pre-renal and a renal cause, we need to do certain investigations to find out the cause because eventually our treatment will depend upon what is the cause. ठीक? So for that, the best thing will be doing checking the urine में sodium quantity. Now, kidney का काम क्या है छोटू? Kidney wants to absorb all the sodium. So patient's kidney is gone. Patient is not able to make the urine. Very less urine quantity is coming. But if in this urine you are finding too much of sodium, that means kidney is not working. It's a renal problem. And if the urine is less, but you see no sodium, that means kidney is trying to absorb the sodium still. So kidney is not the problem, pre-renal. So more sodium in the urine, renal cause. Less sodium in the urine, pre-renal cause. सिर्फ इतनी बात याद रखनी है. यहाँ पे pre-renal most common है, hypovolemia. Then obviously everything will get deranged. Serum creat will rise. Sodium in the blood will be less because you're losing it. Potassium will be high because you're not able to excrete it. KIM1 is the best investigator. मैंने आपको बताया urinary sodium आपको देखना है. If it is less, it is before the kidney. If it is more, it is the kidney. है ना? Fractional excretion of sodium याद रखो छोटू. That is less than 1%. मतलब सोडियम नहीं आ रहा है यूरिन के अंदर. That means kidney is not at a problem. So where is the problem? Before the kidney. And if the urine is having too much of sodium, more than 2%, then it is intrarenal. Treatment to give IV fluids in these patients, saline in these patients, pyrosamide to manage the perfusion, to manage the potassium levels, calcium gluconate you can give for potassium hyperkalemia. आपने medicine में भी देखा होगा cardiology में. Calcium gluconate to basically not allowing the muscle to get problem. Then you can give insulin because insulin and potassium they are inversely proportional to each other. Patient is having too much of potassium in the blood, so you give insulin these patients, petiromer and hemodialysis. Uremia होगा तो hemodialysis करना है because uremia can cause uremic encephalopathy, so you need to do hemodialysis. And for hypertension, give the antihypertensives. This is your AKI. Then when we talk about CKD, CKD में देखो AKI में we had 3 stages, CKD में we have 5 stages, and they are basically dependent on the GFR. So देखो, what is the most common cause of CKD? Diabetes mellitus. If somebody is having type 1 diabetes, it will take around 5 years. If the HbA1c is continuously more than 7, then 5 years to develop a CKD. And for diabetes mellitus type 2, it will take around 20 years if the HbA1c is more than 7 to develop a CKD. Most common used technique to check GFR is serum creat. more specific in insulin clearance, but the best is cystatin C. The formula we are using is Cogrot formula, and the stages of CKD are five, depending basically on the GFR. More than 91, 60 to 92, 30 to 63, 15 to 34, and less than 15 G5. Second criteria on which the CKD is dependent is your albumin loss in the urine. Normally, we are losing less than 30 milligrams of albumin per day or on per gram of creatinine. This is normal, A1. If it is 30 to 300, A2, microalbuminuria. It is more than 300, macroalbuminuria. But basically, we are doing it on the basis of GFR. So in G1 stage, the patient is having more than 90 GFR, the patient remains asymptomatic. In G2, hypertension will come in picture. G3, anemia, because kidney is an organ which is secreting erythropoietin for RBC production. So anemia will occur, and then acidosis and uremia. Now, when the patient is moving from G2 to G3, you have increase in the parathyroid hormone because kidney is not working right. So you are not able to activate vitamin D and you are not able to maintain the calcium of the body. Calcium of the body is going low when the patient is in CKD. So parath hormone will start working, more bone resorption will occur and more calcium will get into blood. And when the patient is moving from G3 to G4, it increases the phosphates in the blood because phosphate needs to be excreted by the kidney, but now the kidney is not working, so phosphate will not be excreted. So eventually, in the patient of CKD, when the patient is in G3, G4 stage, calcium phosphate increases, and calcium phosphate can cause atherosclerosis. So all the patients of CKD in a severe CKD situation, they have at high risk of atherosclerosis. Okay. Then treatment. H4ED. First three stages can be managed conservatively. For your G4, G5 stages, the end-stage renal disease kind of a thing, you need either hemodialysis or renal transplant. H4ED में क्या है बेटा, hyperglycemia, give the drugs which by which you can manage the patient, but very important, metformin has to be stopped, and you have to start with insulin also in these patients of the CKD. I mean, however, they are the patients of type 2 diabetes mellitus, where insulin doesn't have too much of a role, but now the patient is having complication, right? And if you remember, in diabetes, when I taught you, I said that any patient having complication, you have to start insulin. That is the reason, because you cannot give the drugs because they will damage the kidney more. So 80% of maximum dose of insulin has to be started. Hyperkalemia के लिए give calcium gluconate, patiromer. For hypertension, give antihypertensives, and for hyperlipidemia, give statins. For vitamin D, बेटा vitamin D, ED है ना, तो vitamin D, kidney secretes a hormone which activates vitamin D, which manages your calcium in the blood. But now the kidney is gone, so you are having decrease in the vitamin D. And when the vitamin D is decreased, calcium is decreased. So therefore, whenever there's a kidney problem, you need to manage the calcium in the blood, and therefore you see hyperparathyroidism because it is happening due to CKD. So it will be called as secondary hyperparathyroidism. You do more bone resorption, and it will be called as renal osteodystrophy. You increase the calcium in the blood. But because the kidney is failing, so even the phosphate is more, and every patient of CKD has a high risk of going into atherosclerosis because of high calcium phosphate. ठीक है? Erythropoietin is not also not secreted. Patient can go into anemias, severe anemias in these patients. So you give erythropoietin from outside, either subcutaneous or intravenous. ठीक है? But if the patient goes into G4, G5, when the GFR is very low, either you do hemodialysis or you do renal transplant. For renal transplant, we know that we have to do HLA matching and blood grouping. The donor kidney will be from the left side because of the length of the vessels, and recipient you put on the right side in the iliac fossa. Okay? It gives proper support to the kidney. Cell responsible for graft rejection, we have done this before, T cells. And you do technetium 99 DTPA scan for assessing the GFR of kidney individually. And whichever kidney has got more GFR, obviously you do not take out that kidney that is remaining with the donor, and you take out the kidney which is having less GFR. Okay. Then risk of infection after transplant, the most common virus is CMV, but if they're saying more than 6 months, then polyomavirus. After transplant, the most common cause of death are the cardiovascular diseases. Most common cancer, which is seen with the patients of CKD, is skin cancer. And the rejection, there can be three kinds of rejection: hyperacute, acute, and chronic, type 2 and 4, and type 4. This we have done in immunity chapter in pathology. Then the hemodialysis, it is just a diffusion, passive diffusion. This is the principle of hemodialysis, and there are complications associated with hemodialysis. Hemodialysis ka acute complication is hypotension more commonly, and the chronic complication is aluminium toxicity leading to cerebrovascular accidents. And even cardiovascular accidents can also be seen Now, whenever we are doing hemodialysis, you have to make a fistula. I hope you remember which between which vessels, radial artery and cephalic vein. You call it as semenobrescia fistula. Okay, and this is how you are doing it. And as I said, that aluminium toxicity can be seen in these patients, leading to cerebrovascular or cardiovascular complications. Then glomerulonephritis. देखो बेटा glomerulonephritis में glomerulus is the area which basically is excreting harmful metabolites from your blood, and for this excretion purpose, for this filtration purpose, you require three things in glomerulus. What are these three things? Your endothelial cells, your basement membrane, and your podocytes. So filtration unit is made up of these three things. Glomerulonephritis, whatever glomerulonephritis will be seen, they will be autoimmune in nature, either by type 2 or by type 3 or by type 4. So these immune complexes or the antibodies or the T cells, they will come and damage your filtration unit. Okay. Whenever we are talking about any filtration unit, we are talking about the most important part of this filtration unit is always the basement membrane. And the second most important part could be endothelial cell or the podocyte, but the most important is basement membrane. And what are the things which does not allow anything to come out? Dekho, normally your situation is this, that you have endothelial cells, you have the basement membrane, you have the food process of podocytes. You see the gaps, but still a small thing like albumin is not coming out. What is the reason of it? Because albumin is negative charge, and your basement membrane and your endothelial cells, they also have negative charge. So, and because these gaps, they are there, they're small gaps. So big cells like RBC, WBC, they cannot come out just like that. So size and charge both are important, but what is the most important thing? And that is your size, not leading to release of big things, but charge. That's more important because it is not gonna allow a tiniest particle like albumin to come out. हालांकि थोड़ा बहुत आता है, there is little bit which will come. ठीक है? Whenever you are seeing a renal biopsy, this is how it looks. As I said, all these circles, they are your glomerulus. Things which are dilated around these circles, this is PCT. थोड़ा दूर जाओगे, bigger dilatation DCT. थोड़ा और दूर जाओगे, bigger dilatations collected. ठीक? This is glomerulus. This is your PCT. This is your DCT. थोड़ा दूर जाएंगे तो PCT दिखेगा, collecting duct दिखेगा. Only thing you have to remember is that on a light microscopy, this pink and blue picture, you never see a podocyte. Therefore, if somebody is having a glomerular damage, in glomerulus, the filtration unit is three: endothelial cell, basement membrane, and podocytes. So if somebody have a glomerular damage, these three can get damaged. To see a damage, these two can be visualized on light microscopy, but podocyte cannot be visualized on light microscopy. Therefore, only with the help of light microscopy, I cannot make a diagnosis. I need to do what? Electron microscopy. This is how the electron microscopy looks. And what is this electron microscopy gives me? But these inside, these are your endothelial cell. This is your basement membrane, and outside, ये जो आपको दिख रहा है, ये food process of podocyte, and this is a podocyte. So your blood comes here, gets all the filtrate will come in this Bowman space. This is the urinary space. Then from here it will go into PCT, then loop of Henle, DCT, and out. All the damage which is seen in the patients of glomerulonephritis, this damage is seen at three places: either at the endothelial cell level, or the basement membrane, or the podocytes. Now these podocytes, they are also called as visceral epithelial cells. Okay, so most important thing is basement membrane. So whatever damage is happening, it will involve the basement membrane for sure, but there can be a damage which is between the endothelial cell and the basement membrane, so subendothelial damage. There can be a damage inside the basement membrane, so intramembranous damage. There can be damage which is beneath the podocyte but above the basement membrane, so subepithelial damage. And there is one more damage which can be seen, that is mesangial, जो मैं यहाँ नहीं दिखा सकता. So for any glomerulonephritis, these four things are important. Now, glomerulonephritis, it is autoimmune most commonly. So it is more commonly due to type 3 hypersensitivity or type 2 or type 4. Whenever there's a type 2 hypersensitivity, only antibody is going and damaging the glomerular capillary loop. So you see a linear pattern. And whenever antigen antibody complex is going and damaging the capillary loop, you see a granular pattern. Okay? To see antibodies in the tissue, you need to do which test? Immunofluorescence. Immunofluorescence. So fluorescent दिखेगा. In blood, if you want to find the antibodies, you do what? You do Coombs test. Whatever be the reason of damage, what is the first thing will start leaking? Protein. So on the basis of proteinuria, your glomerulonephritis is divided into two types: nephrotic, nephritic. If the protein loss is more than 3.5 grams per day, it is nephrotic. If it is less than 3.5 grams per day, it is nephritic. But Just do not think that nephrotic is more dangerous than nephritic, because the damage is more in nephritic and therefore you see more hematuria, more uremia in a nephritic syndrome patient. Okay, why? If the damage is more in nephritic, protein loss is less because all the things are coming together. In nephrotic, damage is a little lesser, so only protein loss is being seen. Big cells आ ही नहीं पा रहे, तो इसलिए प्रोटीन लॉस दिखता है. मैसिव प्रोटीनूरिया मतलब नेफ्रोटिक सिंड्रोम. सब नेफ्रोटिक प्रोटीनूरिया means nephritic syndrome. In this protein loss which you are having, maximum protein you are losing is albumin, but you are also losing IgG antibodies, so infection can occur in a patient of glomerulonephritis, and you are having release or loss of protein CNS and antithrombin T, which are antithrombotic proteins, which does not allow the blood to make clots. But if you are losing it, so there are high chances of having clot formation in these patients who are having glomerulonephritis. Now, nephrotic syndrome examples are these MCD, FSGS, MGN, MPGN, DNN, CNS, and you have three in nephritic syndrome, that is your PSGN, RPGN, and IG nephropathy. Okay. Now, the tests which you are doing, there are multiple tests, but the best test, the first test we are doing is ACR, albumin to creat ratio. That gives us even a minor injury to the kidney. Okay. Now, we will discuss all these diseases, but I'm not going to say everything. I'll just tell you what is important to learn so that you can solve the questions. Nephrotic syndrome, this is the most common cause of proteinuria in child. Secondary cause, देखो प्राइमरी सबका ऑटो इम्यून है भाई. सेकेंडरी कॉज इज हॉजकिंस लिम्फोमा, यू हैव टू लर्न. एंड माइक्रोस्कोपी में ऑन इलेक्ट्रॉन माइक्रोस्कोपी, लाइट माइक्रोस्कोपी में कुछ नहीं दिखेगा. व्हाई? बिकॉज द डैमेज इज इन द पोडोसाइट एंड पोडोसाइट कैन नॉट बी विजुअलाइज्ड ऑन लाइट माइक्रोस्कोपी. सो यू हैव टू लर्न loss and effacement of podocytes, food processes. That's what happens in minimal change disease. It's highly responsive to steroid, so it is also called as steroid responsive glomerulonephritis. And if it becomes steroid dependent, you give cyclophosphamide. If it becomes steroid resistant, you start with cyclosporin. Okay. FSGS, focal word less than 50%, diffuse more than 50%, glomerular involvement. So कोलाजन स्क्लेरोसिस आ रहा है ना, कोलाजन डिपोजिशन होगा इसमें. ठीक है. इट इज द मोस्ट कॉमन कॉज ऑफ नेफ्रोटिक सिंड्रोम इन द एडल्ट्स. सेकेंडरी कॉज आपने एचआईवी याद रखना है. एंड द वर्स्ट वेरिएंट इज कोलैप्सिंग वेरिएंट विच इज एसोसिएटेड विद एचआईवी. बात खत्म. बस इतना ही याद रखो, क्वेश्चन सॉल्व हो जाएगा बेटा, पक्का प्रॉमिस. ठीक है. एमजीएन, मोस्ट कॉमन कॉज ऑफ नेफ्रोटिक सिंड्रोम इन द ओल्ड एज. सेकेंडली जो तुमको याद रखना है, दैट इज व्हाट, दैट इज योर हेपेटाइटिस बी एंड सी. Very important. And third thing, क्या मिलेगा? That is your spike dome appearance. Because you're having subepithelial deposits and it is giving you spike dome appearance. ठीक है? बस. That's it. Then MPGN, again, it can be seen in the old age. Even in adults, it can be seen. So nothing with the age group here, but it is nephrotic, nephritic both, but more nephrotic. Patient टाइप 3 है ना बेटा, ये टाइप 3 हाइपरसेंसिटिविटी में कॉम्प्लीमेंट लेवल्स कम हो जाते हैं, तो हाइपोकॉम्प्लीमेंटीमिया. You have to remember only one thing. The cause is same as MGN, hepatitis B and C. So if hepatitis B, they are asking, better is MGN, but you can also choose MPGN. But you remember the appearance here. Tram track appearance. Bus. Because intramembranous deposit can be seen. MPGN is of three types. But अपन ने याद क्या रखनी है? Type 2 intramembranous dense deposit disease, जिसके अंदर अपने को क्या मिलता है बेटा? Duplication of the basement membrane, tram track appearance. और कहाँ मिल सकती है tram track appearance? Bronchiectasis. And kidney में MPGN. Diabetic nephropathy, very important. Most common cause of CKD. The first thing which you see with the patient of diabetic nephropathy is kidney trying to save itself, increase in the GFR. First clinical thing, microalbuminuria. ठीक है. Best screening test, ACR मैंने आपको बताया, albumin to creat ratio. Bilaterally, a large kidney on the USG you will find. If you do a renal biopsy, earliest finding on a renal biopsy will be glomerular basement membrane thickening. Most common finding will be diffuse glomerulosclerosis. More than 50% of glomerulus involved, but ज्यादातर यही आता है बेटा, most characteristic finding. That is your Kimmelstein-Wilson lesion. Nodular glomerulosclerosis. तो कौवा lesion मैंने कई बार बोला ये चीज. But if the kidney is getting involved in the PCT region because of diabetes, then you see Armani abstin. And if the DCT is involved, ENaC channels will be gone, your aldosterone will not be able to work, patient will have salt wasting, hyperkalemia, metabolic acidosis. Opposite of hyperaldosteronism, because aldosterone काम ही नहीं कर पाएगा यहाँ. ट्रीटमेंट अभी मैंने बताया बेटा आपको सीकेडी में. स्टॉप द मेटफॉर्मिन, स्टार्ट विद इंसुलिन. 80% ऑफ मैक्सिमम डोज. हाइपरटेंशन के लिए एसी इनहिबिटर्स. पोटेशियम के लिए पेटिरोम और कैल्शियम ग्लूकोनेट एंड इफ ट्रांसप्लांट इज नेसेसरी इफ द जीएफआर goes less than 20, less than 15, 20 like that. This is your diabetic nephropathy. Congenital nephrotic syndrome, it is the problem in the proteins of podocytes. Podocytes have got nephrin and podosin. So if a nephrin gene is mutated and we do not have the nephrin protein, then this is called as congenital nephrotic syndrome 1. And if podosin is gone, congenital nephrotic syndrome 2. NPHS1, NPHS2. Podosin, P for podosin, it's a poor prognostic disease. Child is born with it. It's a congenital problem because it's a genetic defect. Okay? The child is born with generalized swelling, anasarca, foamy urine, hydrophytalis can occur. You will see proteinuria, but selective proteinuria because only albumin loss in majority of patients. Symptomatic treatment is required. Lifelong albumin infusions can be required, but if it's a severe form of the disease, kidney transplant also is needed. Then comes your nephritic syndrome, PSGN. Again, beta, moti moti baat yaad rakhenge. More common cause of nephritic syndrome or hematuria in a child. PSGN, hypocomplementemia because type 3 hypersensitivity reaction. The cause is group A beta hemolytic streptococci, molecular mimicry. RA में पढ़ाया था मैंने, RC में भी पढ़ा है. ठीक है, molecular mimicry और cross reactivity. Patient को क्या मिलेगा छोटू? Cola colored urine in a patient. This is happening after the infection, but this takes 7 to 10 days to 14 days in development. So complement levels अगर लो हैं तो PSGN हो जाएगा और हिमेचूरिया हो रहा है. ठीक है, नॉर्मल आईजी नेफ्रोपैथी अभी बताता हूं मैं आपको. एंटीबॉडीज का नाम याद रखने की जरूरत नहीं है. जस्ट रिमेंबर दिस, दैट लंपी बम्पी बच्चे में हो रहा है ना बेटा, खून बच्चे में निकल रहा है, हिमेचूरिया इन अ चाइल्ड. और जब अपन बच्चे थे तो अपन हम्टी डम्टी याद रखते थे. तो लंपी बम्पी डिपॉजिट्स एंड स्टारी स्काई अपीयरेंस, बिकॉज टाइप 3 है तो स्टारी स्काई मिल जाएगा. स्टारी स्काई अपीयरेंस, this is your PSGN. But remember that hematuria in a child will occur after 10 days, 7 to 10 days of infection. Whereas if you RPGN, I'll come later, IgA nephropathy, but it is the most common glomerulonephritis overall, most common cause of hematuria in any age group. फर्क कैसे पता चलेगा whether it is PSGN or IgA question? One is C3 levels. If the C3 levels are low, it is PSGN. If the C3 levels are normal, it is IgA. पहली चीज. Secondly, if the hematuria is very acute, I mean after 2 days of infection, it is IgA because IgA is very acute. Which antibody? IgA1 antibody will cause the disease. IgA2 is a soluble antibody, it never causes the disease. So this is the difference between IgA and PSGN. RPGN, but RPGN is not a disease in itself. It's a manifestation of other glomerulonephritis. So let's say that any kind of glomerulonephritis which is due to type 2 hypersensitivity, if it is going into renal failure, it is type 1 RPGN. Type 3 hypersensitivity glomerulonephritis going into renal failure, type 2 RPGN. Type 4 hypersensitivity glomerulonephritis going into renal failure, type 3 RPGN. Why renal failure occurs in RPGN? Because these glomerulonephritis, they are making crescents inside the glomerulus. What is crescent? Half moon shaped structure. What it is made up of? Macrophages, lymphocytes. Okay, a lot of things will be there, but they do not contain podocytes. Visceral epithelial cells are not involved. Parietal epithelial cells are involved. Okay, so this is what is written, that crescents, they are made up of lymphocyte, macrophage and parietal epithelial cells, but not the podocytes. जितने ज्यादा क्रीसेंट होंगे उतना ही जीएफआर कम, वर्सर इज द प्रोग्नोसिस. एंड यू सी flea bitten kidneys here. Goodpasture syndrome, which is your type 2 hypersensitivity. ठीक है, if somebody is suffering from Goodpasture syndrome and the patient is going into renal failure, that means the patient is having RPGN1 because देखा है ना, anything having type 2 hypersensitivity going into renal failure, RPGN type 1. So good pastures के लिए 1, 2, 3, 4, 5. It's type 1 RPGN due to type 2 hypersensitivity. Alpha 3 chains of collagen damage. Type 4 collagen होता है बेसमेंट मेम्ब्रेन में, उसका डैमेज है. And it involves kidney and lungs. ठीक है, आईजी मैंने आपको पढ़ा दिया बेटा. This differences I have already told you. Just remember that to treat the hypertension in the patients of IgA nephropathy, we use AC inhibitors, the best drug. But for PSGN, we give pyrosamide. ये आप अपने आप भर लेना. इसमें वही चीजें हैं जो मैंने आपको बोली हैं. These are the only things which you have to remember. And for Alport syndrome, it is hereditary nephritis. XLD है ये, so male to female ratio same रहेगा. And Alport के लिए Alport याद रखना है. 3 organs are getting involved: kidney, eyes and ear. Eye के अंदर you are finding anterior lenticonus and subluxation of lens. And ear के अंदर you are seeing sensory neural hearing loss. And kidney में you are seeing a basement membrane damage. Which chain of basement membrane? Alpha 5 chain of basement membrane, type 4 collagen. So in your exam, it was call 4A5 damage. कोलाजन 4, अल्फा 5 चेन डैमेज, एल्पर्ट सिंड्रोम, थिन बेसमेंट मेम्ब्रेन हो जाती है इसके अंदर, बट इट्स नॉट अ थिन बेसमेंट मेम्ब्रेन डिजीज बिकॉज थिन बेसमेंट मेम्ब्रेन डिजीज यू हैव अल्फा 4 चेन डैमेज. So alpha 3 chain damage, good posture. Alpha 4, thin base membrane. Alpha 5, Alport syndrome. And which appearance do you see? Basket weave appearance in the patients of Alport syndrome. ठीक है? Then pyelonephritis. Any other damage than glomerulonephritis in the kidney is pyelonephritis. मैंने आपको बोला chronic pyelonephritis आपको याद रखनी है. Thyroidization of the renal tubule and staghorn calculi. ठीक है, इसमें कुछ है नहीं. Polycystic kidney disease, adult and childhood. Adult is AD, PKD1 and PKD2 gene defect. It is less severe in comparison to child because the cyst which we are seeing is only seen in the liver, whereas in childhood it is AR in inheritance, PKHD gene present on chromosome number 6. It can involve lungs and your kidney both, so more dangerous. Renal tumors, most common is secondary. You have to talk about Wilms, the most common primary malignant tumor of kidney in child. Wilms tumor, WT1 and WT2 gene on chromosome 11p. अपन ने पैथो में याद किया था छोटू, and it's a triphasic tumor where the tumor cells they are called as blastomal components. ठीक है. RCC, most common cause is smoking. This is the most common malignant cancer in primary malignant cancer of kidney in adults. It has got 5 types. The most common type is clear cell. ठीक है. Second most common type is papillary clear cell. You see VHL gene mutation or 3p chromosome, and in this it is associated with hemodialysis. Very 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 important. A beta 2 amyloid will be seen. आपको याद ही होगा I suppose. Med gene with papillary and translocation 710 trisomy 71017. ALL के लिए याद रखना छोटू translocation या trisomy, that is your 4710. Then the best prognosis is chromophobe and worst prognosis is Bellini's. Okay. Last thing, urine examination. You can see 5 things. RBCs, more than 3 RBCs or equal to 3 RBCs in high power field into 10 because we have to see 10 fields. You call it as hematuria. More than 5 WBCs into 10 per high power field, more than 50 total. Pyuria. पायूरिया में बेटा आपको बैक्टीरिया अगर नहीं मिल रहा तो यू आर कॉलिंग इट स्टेराइल पायूरिया, एंड स्टेराइल पायूरिया जो है दैट इज सीन इन टीबी. You can see crystals. I will tell you important crystals to learn. You can see cast, which are the byproducts of tubule and the epithelial cells. So what are the crystals you have to learn? Crystals में बेटा आपको याद होना चाहिए ट्रिपल फॉस्फेट स्ट्रोवाइड क्रिस्टल. एग्जाम क्वेश्चन है ये. दिस इज द मोस्ट कॉमन एल्कलाइन क्रिस्टल. ठीक है. It is coffin lid shape. Then you have the hardest crystal, that is cysteine, and leucine, which is having concentric rings. Then you have the most common overall crystal. It is the most common overall. It is the most common acidic. That is your calcium oxalate dihydrate. This is envelope shape. And then calcium oxalate monohydrate also is there, which is rhomboid shaped, double shape. And tyrosine crystals, beta, they are needle shape in bundles actually. Then caste में बेटा ये कास्ट तो याद करके जाना. हाइलिन कास्ट नॉर्मली दिखती है और प्रेग्नेंट फीमेल में और डिहाइड्रेटेड इंडिविजुअल्स में. आरबीसी कास्ट इन नेफ्राइटिक सिंड्रोम्स वेर एवर यू आर लूजिंग ब्लड. WBC class in in the infections like in pyelonephritis you will see. Muddy brown cast in acute tubular necrosis and waxy cast in CKD. Question आ सकता है direct. ठीक है. So this you have to learn. So this is a quick recap of all what we have done in kidney, and I just want that you whatever I have said, just first this much of understanding you should have and this much of learning you should have, and after that you see the questions you'll be able to solve them, majority of them. I hope it will help. Bye bye. Take care.